Welcome to SVINutes. I'm May Nour, a vascular and interventional neurologist at UCLA Health and the director of the UCLA Health Mobile Stroke Rescue Program. Today, we're going to talk about changing the landscape of pre-hospital care for stroke. As you know, there are two landmark trials that showed the effectiveness of mobile stroke units in ischemic stroke, Be Proud in Berlin and Best MSU in the US. In over 3,000 patients assessed, mobile stroke unit patients who were treated earlier did much better than patients treated later in the emergency department. To give you the magnitude of benefit, out of 100 patients who were treated on a mobile stroke unit earlier with an IV thrombolytic rather than later in the emergency department, 27 had a less final disabled outcome, including 11 of whom who were disability-free. Mobile stroke unit brings the hospital to the patient, but the complication is, how do we bring the hospital to the patient at the time we need it most? Let me give you an exemplar case. This was a dispatcher impression of headache. The mobile stroke unit team attached in case this was a headache that we were needed for. This patient had a history of hypertension, was hypertensive on scene with a Lamb score of 0 and with an NIH score of 0. No other neurological findings were there. She only had headaches, diaphoresis, and emesis. Let me show you what happened with this patient. As you can see here, there's an intraventricular hemorrhage and stemming from the caudate head on the right side. And you can see that the CT angiogram demonstrates multiple intracranial aneurysm at the MCA bifurcation. This image shows you the first in the world multi-phase CTA in a stroke ambulance. This multi-phase CTA demonstrated beautifully a CTA spot sign that you can see between arterial, early venous, and late venous blossoming. And you can see the images here. As you can see now, the blossoming of the CTA spot sign. We were able to help control the patient's blood pressure in the field, give them anti-epileptics and antiemetic, and take them most appropriately to the destination they needed. And it was because of this imaging in the field. But how do you allocate this resource when this was dispatched as a headache? This is the problem. So to define this, there's a dispatcher impression when someone calls 911 that somebody gives an impression on the phone. And there's a provider impression, the paramedic who arrives on scene and discovers what it is. And finally, there's a final hospital diagnosis. And as these resources need to become effective, they also need to be cost effective. So we need to see the greatest number of patients. So there are challenges to access because of this mismatch or this inaccuracy or ineffectiveness of dispatch. So the solution is to leverage innovations in EMS dispatch in order to allocate these resources. There's considerable amount of inaccuracy and inefficiency. This table shows you 20 mobile stroke units that were surveyed to see how many patients they were dispatched to and how many patients they treated. And you can see there's a huge disproportionate amount. These are the dispatches and the diagnoses of the patients who were admitted to these units. So the future of MSU dispatch is bright, because we have the ability to innovate in EMS dispatch. Innovation through AI-powered decision support system, through predictive analysis, through automated speech recognition, through AI-enhanced triage systems, and integration with wearable technologies. This is the future. This is how we're going to allocate these resources and make them more effective. Although we've made a lot of strides in the care for mobile stroke units and in innovation in the field, what we still have left, which is a big component of care, is allocating this resource to the right number of patients. I think the future is bright, but there's still a lot of work ahead. Thank you very much.